So in terms of what the SHMI is, as I said, it's the summary, which is a comparison of the number of actual patients who die following admission to hospital to the number that we would expect to die given the case mix of patients that are being treated within the hospital. It is now at the hospital level, and it's used, it used to be at the trust level. Now, the reason we did that was in order to understand the different sites that make up a trust, and therefore we can score each of those sites independently, but also deliver a trust level measure, and I'll go over that in detail. The third element of the SHMI is mortality. So it measures the number of patients who are admitted to non-specialist acute trusts in England who died either while in hospital or within 30 days of discharge from hospital. So that's the key to the SHMI, I suppose, and makes it slightly different to some other metrics, is that it does actually measure all deaths that occur in hospital, no matter how long that patient was in hospital for. And it's also an indicator. And an indicator is simply a measure of something in health and social care, which can be used to track that thing over time or to understand performance. So just a very brief history of the SHMI. So a review was undertaken in 2011 of the hospital standardized mortality ratio, which we'll discuss in a few slides' time. And that is a commercial tool that is used to measure mortality. And the recommendation of that particular review was that the NHS should develop their own indicator for mortality. So an expert technical group was set up to agree on the specification of the SHMI, and I believe that included Mohammed, who is presenting next. I know he's definitely a member of the current engagement group, but it also included a lot of individuals from medical organisations as well as from universities. So as a result of that, the steering group were able to define the high-level requirements under which the SHMI would be developed. And then a detailed independent modelling exercise was undertaken by the School of Health and Related Research, which is part of the University of Sheffield. So they built the SHMI, and then it was passed to NHS Digital to run over time. Now, the SHMI has undergone a few modifications since that time, but this current round of modifications is probably the largest that it's gone through, and ultimately it will change a number of key elements that make up the SHMI and the definitions that underpin it, but I'll come on to that later in the presentation. So in terms of how the SHMI works, I suppose in order to understand how the SHMI works, we have to cover off hospital episode statistics data. So the HES data, as we call it, records the number of people admitted to hospital, outpatients and A&E, but we focus on what we call the APC data, which is the hospital admissions. And that contains a primary diagnosis code for the main condition that the patient is in hospital for. But it also records a series of comorbidities, and the number of comorbidities or secondary diagnoses codes that are recorded does depend a little bit on the type of system that the hospital is using or the trust is using. So some record up to 19 different comorbidities, others record less. So we do have a contextual indicator for that, and I'll talk about that a little later. Each of these diagnoses are coded using the International Classification of Disease, or as it's more commonly known, ICD, and in this case it's ICD version 10. And there's approximately 70,000 different codes there. So what we do for the SHMI is we take each of those ICD-10 codes and then we aggregate that up using the clinical classification software categories, of which there are about 260 codes. Then we take all of those and we aggregate them up further using clinical expertise and come up with a reduced group of 142. And those 142 are what we regard to be the primary diagnoses that we then analyse. In some cases, a specific diagnosis can't be made, so we give the record a primary diagnosis code corresponding to what we would regard as a symptom or sign, and again we create a contextual indicator for that, and I'll discuss that later as well. The HES also records information relating to the patient, such as age and gender, etc. So, as it describes there, the HES is hospital episode statistics. So it's probably worth understanding what we mean by episodes and then the grouping together of those episodes into spells. So if we take a patient that's admitted to hospital with a broken leg, for instance, and that patient is treated by consultant A, then that would be regarded as episode 1. If while that patient is in hospital, a blood test is done and they're diagnosed to have diabetes, for instance, and then they're treated by consultant B, then that would be considered episode 2. And that goes on, etc. And that is what we regard to be a spell. And a spell would end when a patient is discharged, dies, or transferred to another hospital. So there are certain instances that we therefore need to consider. So if we imagine a scenario whereby episode 1 and episode 2 were within a particular trust or within a particular hospital, and then for episode 3 that person needs to be treated for a diagnosis that that particular hospital doesn't deal with, in simplistic terms, then they may be transferred to another hospital. So that might be in trust 2. When a patient is discharged, as I said above, or transferred to another hospital, then effectively the responsibility for that patient therefore passes to trust 2. So if the patient were to die as a result of post being transferred to trust 2 or within 30 days of discharge from trust 2, that death would be purely allocated to trust 2. The fact that they were transferred from trust 1 to trust 2 becomes irrelevant. The death is solely allocated to that final acute trust that treated them. But when we put those two sort of provider spells together, we get a continuous inpatient spell. So the patient was in hospital for that entire period. Maybe they were transferred within that period. So we have 2 provider spells, one for the first hospital, one for the second hospital, but then we have a single continuous inpatient spell. And that's what we call a KIP within SHMI terminology. So then in terms of the main principles with regards to building the SHMI, what we have the HES data, as I've just described, which is all those episodes. And within the HES data, we actually record in-hospital deaths, but we're also interested in whether or not the patient died within 30 days of being discharged from hospital. So we use the ONS deaths registry data in order to identify those particular individuals. We then take that data and we filter out a number of subpopulations. So we remove specialist trusts such as community trusts and mental health trusts. We remove day cases, regular attenders, stillbirths are removed. We allocate the death to the last non-specialist acute trust, so taking into account what I've just discussed with regards to transfers. And we also calculate what we call a comorbidity index from all those secondary diagnoses. And as I described, there could be up to 19 of those secondary diagnoses. We then build 142 logistic regression models, and this is repeated on a monthly basis. And we create a series of outputs associated with the SHMI. So some of them are reports on data quality, some of them are, as you can see there, VLAD chart, which I'll describe in a bit more detail later. We create a one-page summary and we also output some data. Again, I'll go over in more detail the specific outputs later. So just to go into a little bit more detail on that modelling approach, it's probably worth saying that when these were initially built, a relatively simplistic approach was adopted in terms of the variables used within the model and also the techniques that were employed. And we've been revisiting that, but it has to be appreciated that data quality has improved substantially since these were first built in 2011. So what we have is we have 3 years of data that we use to build the model. So we have sufficient volumes within each of the diagnoses groups that we're analysing, but we only score the last 12 months of data in order to calculate the SHMI value for that particular site or trust. So we then create 142 diagnosis group models, and that could be models relating to tuberculosis, thyroid disorders, pneumonia, etc. So each of them would have their own model. However, the variables used within the model are relatively consistent. So it's a similar set of variables orientated around the sex of the individual, the age of the individual in 5-year bands all the way up to 90 plus, comorbidities. So we use the Charlson comorbidity index, which we'll discuss a little bit later. We'll consider admission method, whether it was elective, acute or unknown, but we also now include birth weight for a small number of the perinatal models that we have within the SHMI. So each of those models gives a probability of death to each patient based on the diagnosis, the primary diagnosis that they were in hospital for. So we effectively add up all of those probabilities and we get an expected number of deaths that would be associated with the patients that we're analysing for that site or trust over that 12-month period. We therefore compare the number of observed deaths within that site or trust to the expected number of deaths, and obviously that gives us a ratio. A ratio above 1 means that there were more deaths than we would have expected for that particular trust. A ratio below 1 indicates that it's below what we would have expected for that particular trust. So we then plot each and every trust using a very simple funnel plot chart, and we compare that to 95% control limits, and we categorize each of the trusts as to whether, and each of the sites I should say, but this is trusts on here, whether it is higher than expected, as expected, or lower than expected. And we use control limits that account for over-dispersion. So over-dispersions where there's greater variability in a data set than we would typically expect given a particular statistical model. And it's a really common feature in applied data analysis because in practice populations are frequently heterogeneous, i.e. non-uniform, which is contrary to the assumptions implicit within sort of widely used parametric models. So by ensuring that we do that sort of trim for over-dispersion, we don't get as many as if we hadn't done the trim in the higher than expected or lower than expected. And there is a whole range of debate, and this debate has been going on for a number of years as to whether this is the appropriate way of doing it. And initially there were different methodologies applied to this, and we published multiple methodologies, but this is the approach that we currently publish, but we will be reviewing this as part of the current review. So in terms of using the SHMI in practice, it's important to understand what the SHMI is and what it isn't. So it's supposed to be an indication of an issue, And that issue may be that there's a problem with mortality within a particular department within a hospital, but it could also be that data quality has gone wrong in a particular month when they've supplied the data to us, or they're not recording something correctly. It's a tool to be used in conjunction with other tools, and it feeds into reports that the CQC would undertake, for instance, when they're assessing a site or a trust. And as I said, it's a smoke alarm for further investigation. It's not meant to be a ranking of the various trusts, a measure of avoidable deaths, i.e. we don't calculate observed minus expected and say, well, this is the number of excess deaths that have occurred within this particular site or hospital. And it's not a judgment of quality of care, because there are many factors that could affect the SHMI. We create a number of outputs to support that. So as I showed a little bit earlier, there's the one-page summary, very hard to see, but it contains that funnel plot and a summary of the trusts that are higher than expected and lower than expected. We publish the SHMI at trust level and site level. We publish the SHMI for certain diagnosis groups. We create a background quality report. So recently there was an issue with the submission for one particular trust of their end of year data that resulted in a significant impact on their SHMI value, but we were able to report that that particular issue was due to data quality and not due to any, well, not necessarily that particular issue due to any issues with that trust. We create online interactive dashboards using Power BI, and we publish the statistical model data. We also create a series of outputs just for trusts, so we give them their record level data back with the SHMI appended, and we also create VLAD charts, which is this variable life adjusted display chart. So that's a VLAD chart on the right hand side, and I won't make you read all the text below, but basically it says on the x-axis we have all the spells and they're ordered by the discharge date. So for every spell we allocate that particular spell a 0 if they survived and a 1 if they died. And associated with that, every spell, as we've just discussed, has a probability of death. So we take this probability and then we subtract from it 0 if they survived, and we subtract 1 if they died. And we plot this value cumulatively on this particular chart. So if you have a high probability of death, say 0.7, but survived, then you subtract 0 from that. So in effect, it's a positive value of 0.7. So that gives you a positive tick up. If you had a low probability of death, say 0.1, and you died, so we take off 1 if you died, then 0.1 minus 1 is minus 0.9, so that would be a big move down. So what we want to see in this chart effectively is lots of probabilities of death but survived, and that means it's ticking upwards all the time. So a positive upward trend is a good thing within this chart, if that makes sense. I've mentioned a few times that we create contextual indicators around the SHMI. And the reason for this is that not all of these factors feed into the SHMI model, but they're important factors that should be considered when you look at the value that we're seeing for that SHMI. For instance, and there's been a lot of debate over time as to whether deprivation and ethnicity should be included within the SHMI model. But if we included, say, deprivation, then we would adjust for deprivation, which would risk removing from the SHMI some of the differences that the indicator's designed to measure. So, for instance, again, relating to ethnicity, if we included ethnicity within the model, that might suggest that a higher death rate for those of a certain ethnic minority is acceptable. And that's not what we want to do. We don't want to adjust the probability of death for ethnicity. We want to understand the probability of death and then look at ethnicity alongside that. And we do this for a number of different factors. So deprivation quintile. So we look at provider spells in terms of deprivation. We look at the depth of coding for those comorbidities. So we might find that, for instance, because one trust is able to gather 19 comorbidities and another trust is only able to capture 12, for instance, that actually, the SHMI value is better for those where we account for more comorbidities. So we record that as well. We look at crude mortality rates for elective and non-elective admissions, the percentage of deaths in hospital and out of hospital, because obviously we're considering all deaths that occur within 30 days of discharge. We consider the proportion that had invalid primary diagnosis, the proportion of spells that didn't have a primary diagnosis but were classified using a symptom or sign, whether there's a site of treatment change. And we've just added another contextual indicator, and that relates to the number of spells that will be removed with COVID-19 coding, and I'll discuss that in the very final slide of today's presentation. So just to cover off some of the differences between the SHMI and other mortality indicators, I've only picked one, which is the hospital standardized mortality ratio that I referenced earlier. So obviously the SHMI is maintained by NHS Digital and HSMR is built by Dr. Foster Intelligence, which is part of Imperial. The SHMI looks at all in-hospital deaths or within 30 days of discharge, whereas HSMR only looks at deaths in hospital, so it doesn't consider the 30 days afterwards. There are some mortality indicators that do it differently again. So, one of the debates that we had for the SHMI was, should it be within 30 days from admission? So there were two aspects of that. There were some fears that individuals may be maintained for longer within hospital in order to make sure that they fell outside of that. It was also considered whether or not that would account for sufficient proportion of the deaths that occur within hospital. And one of the key things that came out of the user group was that they wanted every death in hospital to be considered within the SHMI, well, every death in hospital within the HES data set to be considered within the SHMI. In terms of the clinical classification system group, as I've said, we look at all 260 of them, but obviously aggregate the 260 to 142 models, but all 260 are included. In terms of the HSMR, it looks at 56 of them, but that does account, they are the big ones, so that accounts for over 80% of in-hospital deaths. And obviously, the variables within our model and the variables within the HSMR would be different, but as the HSMR is a commercial product, then they don't reveal as much information as to what precisely feeds into it, but we do know it is just for palliative care. So just finally, before I move on to what we're doing at the moment, in terms of the SHMI, it is a national statistics, which means it is and has been assessed by the Office for Statistics Regulation as fully compliant with the Code of Practice for Statistics. And that revolves around three key tenets, which are sort of trustworthiness, i.e. confidence in the people and organisations that produce the statistics, quality, that we're using appropriate data and methods to create those statistics, and value, that we're doing it in an appropriate way that isn't overly complex and drags it out, takes too long, and actually meets what society wants, i.e. we're actually reflecting user requirements in terms of how we create this. So we're gathering requirements in order to build it in the most appropriate way. So some of those, I'm not going to go through each of these in detail, but if we look at quality, the key one might be sound methods, which considers the types of techniques that might be used in order to build these and recognize standards and us being open about our decision. It's also about clarity of insight. So statistics and data should be presented clearly, explained meaningfully, and provide authoritative insights to serve the public good. And there's another aspect to that, and well, that could be reflected in terms of the methods that we might use to build the SHMI. So if we use the neural net, for instance, does it provide the clarity? Is it explainable, for instance? And then the other thing that I'm going to go on to next is, innovation and improvement. So these types of metrics have to be subject to continuous development, which is what I'm moving on to now. So as I said earlier in the presentation, there were a series of short-term developments that we implemented in May of last year for the SHMI. And a lot of these now are, have been in place for a year, and they've been reviewed by users and refined, and they're absolutely working perfectly. I say perfectly. They have been accepted, and they're part and parcel of the regular publication that goes out. So some of those were changes to the disclosure control methodology in order to ensure that it wouldn't be possible, for instance, to identify a particular individual by looking at the summary results. We've split out a number of diagnosis groups. So specifically, we split out Hodgkin's disease and non-Hodgkin's lymphoma. We also split out live birth from maternity-related conditions. We made an adjustment for seasonality to reflect some of the ways in which data was submitted. We also, as I said earlier, included birth weight in a number of the perinatal diagnosis groups. And I've said this throughout the presentation, we used to report the SHMI at trust level, but that's now done at site level. So it gives a significant degree of granularity. And I'll go over some of the analysis that's been done more recently in order to use that site information more effectively, and what we're doing in order to take that forward as part of the longer term developments. We've also included some SHMI values, bandings and control limits for 10 selected diagnosis groups. They tend to be the bigger ones that we feel comfortable reporting on them at that level of granularity. And it used to be reported on a quarterly basis. It's now reported on a monthly basis. So it's just reflecting what I said earlier about the timeliness of data from the Code of Practice for Statistics. The quicker we get it out there, the more relevant it is. And we've also sped up how we actually publish it in terms of the date ranges that we're using. So we've brought that forward a month as well. And there's a series of long-term improvements that are currently in progress, and these are the ones I'm going to focus on a little bit more now than the short term. So if I'm not going to give you a synopsis of each of these, because some of them I'll discuss as we go along. So 0-day length of stay, I'll cover off. Site classification, integrated trust, I'll cover off. Primary diagnosis. Within this particular aspect, what we are trying to assess is whether we use the primary diagnosis that's captured for the first episode or the second episode, or is it another episode after that. At present, we either use the first episode or the second episode, because sometimes they might get a primary diagnosis when they're first admitted to A&E, but then when they're admitted to a ward, for instance, the diagnosis changes after they've undergone testing, etc. So we do that at the present time, but it might be that we select the most acute diagnosis of all of the ones across all of the episodes, or it might be that we select the last one. We need to do further analysis just to understand which primary diagnosis that we're going to use. The diagnosis groups, I've mentioned a number of times already that we use the clinical classification software in order to take 260 categories and aggregate them to 142. What we are doing is engaging with the clinical teams in order to assess whether that 142 is the right set of primary diagnoses to take forward into the model. It may be appropriate that we aggregate some of them up further. It may be appropriate that we disaggregate some of them and get more granularity within the SHMI model. I'll cover off comorbidities and new data characteristics and the modelling techniques in the presentation as well. And then finally, once we've built the new SHMI solution, it's really important that we present at a level of granularity that allows users of the solution to get the information that they want out of the solution, but without it being misleading, i.e. based on low volumes of data, etc. So one of the things that we really want to do is create a much better understanding of movement over time, time series analysis, etc., but obviously accounted for the fact that the SHMI is produced on discrete populations on a monthly basis, etc. And then, not on here, but there's a whole other issue around suspicion of sepsis, which we have been exploring and finding very difficult to integrate within the SHMI model. And the reason for that is that when you actually get into the detail of what is classified as suspicion of sepsis, and then the number of instances of suspicion of sepsis, if you were to, and we've done a lot of analysis around that, if you were to take all those ICD-10 codes that are currently classified in the suspicion of sepsis model, then it would actually suck up data from the SHMI model and chuck it all into one big pot, which will account for a large proportion of the deaths. But then when you actually get into the detail of how many of those people actually die from sepsis, it's a lot lower than the proportion that it was suck out of the model. So we've been looking at that and whether or not how we integrate that maybe into a characteristic that feeds into the model, or whether we extend the septicemia one that we already have, etc. But lots of debate still to go on around that, and I know it's a very important topic that a number of clinicians want us to examine. So going on to the specifics of some of those issues that we're tackling at the moment, though on pause due to COVID-19. One of them is relating to 0-day lengths of stay and same-day emergency care. And the long-term plan is to record same-day emergency care in the emergency care data set instead of within the APC data set. And this has been a long-standing issue within the HES data set. And one of the reasons that it's been a long-standing issue is due to the four-hour wait limit in A&E, which is one of the key targets that's applied. So what you would see is that and we saw this and we analysed it, as you get closer and closer to the 4-hour wait time in A&E, we see admissions peaking in terms of, well, we'll admit them to hospital and therefore they won't go on that particular, metric, and therefore we won't be negatively impacted by that. But ultimately, what we found is that the recording of same-day emergency care in national data sets is really inconsistent. And based on a survey of providers, approximately 70% of same-day emergency care records are included in the HES admitted patient care data set, and therefore in the SHMI, and approximately 30% of records are included in the outpatients data set, so excluded from the SHMI. And that does make a significant impact. So we did an analysis of the trusts that have previously changed from recording this type of activity within the APC data set to the outpatient data set. And what happens is we see an increase in their SHMI value. And the reason for this is that there'll be lots of these individuals that are admitted to hospital and included in the SHMI, and they all contribute to small probabilities of death. So when we're calculating that expected value, that is the denominator of the sum of the observed divided by the sum of the expected, all these little probabilities are adding up and increasing the size of the expected. But because the majority of these people don't then die, the observed isn't increasing by the same sort of volume. So the observed stays reasonably similar, but the expected, because of all these tiny little probabilities adding up, is increasing, and therefore your SHMI value is being kept slightly lower. So one of the things that we need to do, therefore, is reflect on the strategy for same-day emergency care and how that will be included within the SHMI in the longer term. And obviously, under the long-term plan, every acute hospital with a type 1 A&E department will have to move to this model of same-day emergency care. So we've been looking at 3 different options. One of them is exclude the activity in same-day emergency care units, but there's going to be a significant time before that's fully understood and included with and expelled from the SHMI, so to say, because we're using 3 years to record this data. So, 3 years to build the model. So if we start recording SDEC in a different way from day one, then it'll take 3 years before those types of records fall out of the SHMI. And also, we may then have 12 months that we're scoring, which has no SDEC records in, but 2 of the years that are used to build the model having SDEC records in. So that's difficult. We might want to include the activity that happens in SDEC units, and that would be great because that'll give us a degree of consistency going forward. However, identifying that activity is slightly problematic. People will move to recording SDEC data within ECDS at different points in time, and also it depends on whether the data that's recorded within ECDS is giving us the same level of granularity and the same type of variables that we would have within HES, and there are issues there as well. So ECDS uses SNOMED codes, whereas we're using ICD-10 codes in HES, and it's quite difficult to map from SNOMED to ICD-10. So that's another issue that we need to address. And then the other way of doing it would be just to exclude all 0-day length of stays. But we know that emergency admissions account for, with 0 length of stay account for 21% of spells in the SHMI dataset, but also 6% of deaths. So all of these factors need to be considered, and it's still in debate, but we're doing lots of analysis to explore the most appropriate options. I mentioned earlier that we've been looking at sort of, we've taken the SHMI from a trust level to a site level. So it's worth looking at some of the implications around sites that occur within the SHMI. So if we take an integrated trust, so we may have within an integrated trust an acute hospital and a hospice site offering palliative care. Now, they may be virtually on the same location, they may be separated by a mile, whatever, but they're part of the same trust. We might have exactly the same scenario in a different location where we have an acute hospital, and that is one trust, and a hospice site offering palliative care, which is a second trust. Now, they could also be in very close proximity to each other, but they're classed as different trusts. So in the case of a patient being transferred from the acute hospital to the hospice site, that would actually just all contribute. The patient doesn't fall out of that trust SHMI because it's all happening within the same trust. That patient is still included when they get transferred. So it all contributes to the trust SHMI. And obviously, if they were discharged from the hospice site, it would then be 30 days from discharge. So in that particular case, you have a site SHMI for the hospital of 0.9842, which the AE means as expected in terms of the way that we would look at the funnel plot. And we have for the hospice site, we have a site SHMI of 8.5292, and then an overall trust SHMI of 1.0496, which again is as expected. But that hospice site is, as one would expect, experiencing a high number of deaths. And that is contributing to increasing the trust level SHMI higher than the acute hospitals level of SHMI, but obviously not massively, because the number of patients being or going through the acute hospital would be significantly higher than the number in the hospice site. But what you then have to consider is that fair when you consider two separate trusts? So if we have an acute hospital and they do a transfer across to a hospice site, then ultimately what happens is that when that person or that patient is transferred from the acute hospital to the hospice site, it doesn't stay at that. It isn't the responsibility. If a death were to occur, it isn't the responsibility of that acute hospital. So their SHMI is not affected by the hospice site in effect. So in that particular case, the site SHMI, if it's the only site within that trust, is the same as the trust SHMI. If for that particular hospice site, because it's a specialist site, at present, it doesn't actually get a SHMI value. It's excluded. If you remember that sort of filtering exercise I talked about very early on in the SHMI presentation, then it would actually be excluded at that point. So that makes a significant difference. So we have to, really consider that, and it's further complicated. We can do this at site level within a trust, but it gets a lot more complicated when it's an integrated site. So where maybe the hospice care or the palliative care is part of that acute hospital, but it's separate wards. How do we then identify those particular wards and maybe create a separate SHMI for them and exclude them from the overall acute site SHMI? So there's lots of different ways in which we're doing that. And one of the things that we've already done, and we did this the end of last year, was we actually contacted every single trust within England, and we got them to classify all of their sites. And I think we got a response from all trusts apart from 3 or 4, if I remember rightly. One of my colleagues on the call could probably clarify. And we then looked up the sites within that trust so we could classify them accurately. But it was phenomenal, the number of sites that were misclassified as acute sites when they were offering palliative care or community care, etc. So really important from this perspective that we treat all the sites and all the trusts fairly. So lots of decisions to be made there as to whether we can do the exclusion of specific wards, for example, within a hospital, whether we actually score all sites, irrelevant of whether they're a specialist site. And what we want to do is create an appropriate way of comparing different sites, and that's what that will allow us to achieve. Moving on to comorbidities, the Charleston comorbidity is what we currently use, and what that does is it takes 17 medical conditions and it allocates a weight to each of them. So I've given 2 weights there. Diabetes without chronic complications gets a weight of 3, moderate severe liver disease gets a weight of 18. And what we then do is we aggregate that up and create that very simple set of indicator variables below, which is it gets a 1 if it's a 0, 2 if it's 1 to 5, and 3 if it's greater than 5, which isn't really taking advantage of the granularity within the Charleston comorbidity. What there is also is the Elixhauser Comorbidity Index, and that's a more comprehensive set of over 30 indicators, and they can be used as dichotomous indicators, i.e. you have that comorbidity or not, but there is a way of also summarizing these and creating a single numeric score as well. So that would be an appropriate way of considering comorbidities, which is those 19 or so secondary diagnoses that we talked about earlier. And then we're also looking at a bespoke approach, which is creating an indicator for each of the 142 aggregate clinical classification software groups, so what would be regarded as primary diagnosis groups, and creating separate comorbidity indicators for each of them as well. So what we're going to do is, when we come to rebuild the models, is test every approach, and if one approach works better than the other in a particular model, we may use that approach in that model. It doesn't have to be a consistent approach, as is currently the case across all 142 or whatever that number models there are. Could be one model, could be 142, and I'll come on to that in a few minutes as well. So comorbidities is a way of creating new characteristics, but what we also want to do is consider whether or not we're using all the data that's available to us, but we have to be very conscious of, can we get our hands on the data quickly in order to turn it around within the SHMI model every single month, and we only have approximately a week of data processing, a week of model building and created the report and then publishing it. So really important that it's quick in order and integrated in order to include it. So we're currently examining the various different data sets are available to us. So I've talked about some of them, like the outpatients data set, the A&E data sets, etc., and looking at whether or not we can create new characteristics from that. But we're also looking at the APC data, and are there characteristics within that that we haven't used that are now better data quality than they were when it was first built? Which of these characteristics are really well populated across specific groups of models? So as we just discussed, we don't have to use the same variables in each and every model. So birth weight only feeds into the perinatal models. Are there other characteristics that sit within the data that would only feed into a subset of models, but are very relevant to those models? We're looking at information such as recency and frequency type metrics, such as recency of last visit to A&E, number of admissions to A&E, consistency of the last primary diagnosis if you were admitted to hospital. So lots of new characteristics that could actually improve the predictiveness of our model, and some preliminary analysis have already been completed on that. And we've seen there that number of prior emergency admissions in the last 3 months was a key variable, for instance. Sorry, my slides have paused. I've sort of touched on this a number of times within the presentation, and one of the key things that kicked off a lot of the review of the SHMI was the increased processing power that's now available to us. And I'm sure this gets mentioned a lot, with regards to what we could have done maybe 10 years ago in statistical software doesn't compare to what we can do now. And also the types of techniques that are available to us now. So whether we can use more powerful machine learning techniques in order to build the SHMI model. It's also been raised a number of times as to whether the SHMI should be a single model or continue to be multiple models, and what the definition of the outcome should be. So one of the first things that we did is we investigated a series of alternative approaches and built models based on whether or not it was all hospital admissions plus 60 days from discharge, whether it was 30 days from admission, all those sorts of factors. And we came to the conclusion, after discussing it with the users, that they wanted all hospital deaths. So 30 days from admission or 60 days from admission wasn't going to capture all of them. And though only a small proportion fell outside of that, they felt that it was really important that we include all of those deaths within the model. So the conclusion of that was the users wanted to keep the same definition, and as it's been in place since 2011, they also felt that it would maintain a degree of consistency in terms of the model that we were delivering and the understanding of that model. But what we also wanted to do was look at various different techniques that may improve the predictiveness of those models. So we were considering factors such as the stability of the model, the performance of the models against existing logistic regression approaches, the complexity, the interpretability, whether there should be one model or 142 different models. Also, within all of that, we have to consider, if you use a specific technique, what outputs can you create from that technique, and can you actually interpret the results that come out, and does it meet some of the criteria from the Code of Practice for Statistics? So all of those things have to be considered when we decide which type of technique we employ for the SHMI in future. So we sort of engaged with our data science team, and they tested a series of different techniques in order to assess which of these might be the most predictive. So they looked at logistic regression, penalized regression, decision trees, random forest, neural nets, support vector machine. They looked at latent class regression from a theoretical standpoint, but didn't feel that it was appropriate. And also it had to use a bespoke software package, and therefore it might be very difficult to replicate if other organizations trying to replicate our solutions. But they also looked at standardization. So very simply put, looking at the combinations of the variables and the death rates associated with each combination of the characteristics within each variable. So relatively simple technique, but as we'll see later, quite a powerful technique as well. They built separate primary diagnosis models, so 142 models, and they also built a single global model for each technique. In order to make it comparative with what we do at the moment, they only use the existing SHMI model variables. And obviously they went through the process of optimizing the parameters where possible. And I keep saying they to make sure that you don't ask me any really difficult questions about data science techniques. And the outputs of that were as follows. And what you can see there is, and it's quite hard to see, is that actually the separate forests, so random forest model, performed probably slightly better. It's very hard to see there, but it was marginally better. And that's what the diag means. The diag is diagnostic models, and then the global is global models. So one model versus individual diagnosis, primary diagnosis models, just to clarify that. And then the top one is the SHMI existing solution. And what you can see is that all the techniques are very powerful, but the SHMI existing solution was well up there. However, what we did see was that the standardization approach, which is this very simple technique, actually gave a slightly higher Gini than the existing SHMI model. However, it is at the expense of overfitting, for want of a better way of putting it. Is, you know, there's no real diagnostics here, but it is overfitting because some of the combinations of variables had very small volumes within them, and also some of the combinations were associated with just one trust, for instance. So again, not very appropriate to apply. So as a result of lots of work in order to assess what the most appropriate technique would be going forward, it was actually decided that the current method, and this is backed up by a number of external papers as well, the current methodology using logistic regression, separate models per diagnosis groups, is going to be maintained for the foreseeable future. And while it might not be the optimum technique, it gives us the most appropriate method from a transparency and application perspective. You know, it supports a lot of the existing outputs. Some of the techniques explored wouldn't, so not all of those techniques give you a probability of death. For instance, SVM uses a distance metric, and then you have to try and convert that into a probability. And maintaining separate diagnosis groups allows each of the models, and this is quite important from a validation perspective, to be developed almost independently. So as new characteristics are made available and maybe only are applicable, like the when we're talking about the perinatal models and birth weight, if you just want to implement those additional variables within specific models, you can. Whereas if you adopt a global approach, you then have to go through the process of assuring a much bigger solution than you would if you had individual models. And I've already talked about the issue with the simple standardization model. And then finally, you'll be glad to hear COVID and the SHMI. So obviously, COVID is an extremely prevalent issue right now, and a number of individuals have unfortunately passed away as a result of COVID-19. And that data will start flowing into the SHMI from the July publication. So, as I said earlier, the SHMI looks at 3 years of data and then scores the last 12 months of data. So we expect the COVID-19 codes in the March 2020 hospital episode statistics. So what we're going to do initially is we're going to exclude all COVID-19 diagnoses from the SHMI. So the SHMI isn't designed for this type of pandemic activity, and the stats models used to calculate the SHMI are not going to be as robust if COVID-19 diagnoses were included. The creation of the temporary hospitals, such as the Nightingale Hospital, will mean a certain hospital trust will have disproportionate activity in relation to the SHMI compared to others. And it's going to be inappropriate to ban trusts as having higher or lower expected number of deaths when this could be likely to be a result of the COVID-19 activity. So all spells within the HES data where COVID-19 is identified as a primary or secondary diagnosis code will be excluded. Additionally, and we don't traditionally do this, we're going to be looking at the ONS cause of deaths data and removing those individuals identified on the death certificate as due to COVID-19. And then also it's worth bearing in mind that because all models are built on 36 months of data, if you consider this most recent month that will be feeding into the build of the SHMI, it's only going to be 1 month out of 36 going into the build of the model, but then obviously 1 month in 12 being scored. And in time, there's going to be significant changes in the volume of activity for some of the diagnosis codes as well. So we need to monitor that. So for instance, a lot of elective admissions to hospital would have been sort of postponed or cancelled. We also know that a large number of individuals avoided going to A&E during and still throughout the COVID-19 pandemic because they were fearful of catching something in hospital. Now, some of that has had a very negative effect in terms of people turning up to hospital too late. But also all those, as we discussed earlier, all those little probabilities of individuals that maybe have fed into the SHMI in the past won't be feeding in because those people aren't necessarily turning up at hospital. But what we have to do then is, really monitor the situation and assess what we need to change within the SHMI as time progresses in order to reflect the trends that we're seeing. And then just to summarize, the SHMI is used as a smoke alarm to monitor deaths in hospital or within 30 days of discharge. It identifies potential issues, which could be as simple as data quality. It's built using logistic regression, and it allocates a probability to every acute hospital spell, and that allows us to do a comparison between the expected number of deaths to the observed number of deaths. It's subject to continual improvement, and is currently undergoing a comprehensive review. And as I said earlier, a number of things have already been implemented, such as reporting at the hospital or site level, as well as monthly reporting. And also, the SHMI will be excluding all COVID-19 related admissions, primary and secondary, all within the death certificate for the foreseeable future. I appreciate I've probably overrun in terms of the time that I've been talking, but hopefully there's still time for a few questions, or my colleagues may have answered some questions as we went along.
That's brilliant. Thank you very much, Gary. There's a huge amount of material there. It's a fascinating presentation, and I've seen that colleagues have been asking one or two questions on the sidebars we've worked through. I think maybe it's best if we have sort of 5 minutes or so for questions. I've got one sort of a bit of an insider's question, I guess, which is so obviously SHMI is a relative measure. It's used for comparing mortality rates between trusts, and you're using a model to standardize what the expected level was. And I think you said at one point that some variables don't go into that. So in part you're trying to account for variables that the trust has no control over, like the number of people turning up with broken legs, or sort of case mix and that sort of thing. But then on other variables like ethnicity, you're not putting those in the model. So if ethnicity was having a major effect on mortality rates, and you've got a hospital in Leicester, for example, with a very sort of large Asian population, the mortality rates in those areas might be affected by those ethnicity factors, but not taken into account in the model. And I just wondered if there are any sort of general thoughts about where you draw the boundary on that.
I welcome if Emily or Sally or David wants to come in on this, but I think the idea is, and we've debated this quite often, that there are various factors that you want to analyse alongside the SHMI, and if you've put those factors into the SHMI model, the SHMI would be adjusting for those factors, in which case we'd end up sort of almost implying that differences in mortality or outcomes are acceptable for different ethnic groups if we factor that into the model. So that's why historically the debate has been that we shouldn't put them into the model, and we should analyse the SHMI values alongside those factors such as deprivation, ethnicity, etc. And funnily enough, some analysis has previously proven that there's some form of inverse relationship between deprivation and mortality, and some of that is related to maybe the diet, some of that is related to people turning up at hospital, etc. But if you factor all the things into the SHMI, you're actually taking away from the further analysis that you can actually do, because you're not making it independent. I don't know if Emily or Sally want to come in on that one and give their opinion, because I know that they've done a lot of analysis on this over the years.
Yeah, no. I agree with what you said, Gary. It's I think one of the main things is that if we adjust for some of these factors, we're going to be almost like hiding differences rather than actually being able to see them. But it's not a clear-cut issue.
No.
So just picking up some of the sort of question on the sidebar actually. So C.E. Saville, sorry, don't have that person's full name, has asked where we can get further information about the contextual indicators.
All the contextual indicators are available as part of the standard SHMI publication. So any information that you want is on our SHMI homepage. Well, we produce a SHMI homepage which explains all of the things that go into the SHMI and how it's built, etc. But then on a monthly basis, we create the reports and the contextual indicators, etc. And it is slightly more comprehensive what we produce on a quarterly basis, where we update the sort of dashboards, etc. Yeah, so it's all available on our website, NHS Digital.
Okay. And then a question that I don't understand the question. I'll be upfront. So Tim Davis has asked, do you use your control limits on the funnel plots in a Shewett sense? So distinction between controlled and uncontrolled variation.
Now, this is one that I'm going to hope that Emily can answer, because that is not one that I can answer either.
Yeah, so I think that the purpose of the control limits is to identify variation outside of the expected range. So I'd say the control limits we use on the run charts, the VLAD charts that Gary demoed, are much more similar to some of the Shewett type methodologies. But yeah, the principle is looking at things that are outside of the expected norm. So a process that's moved out of control in the Shewett sense. But of course, there's considerable debate about exactly how you calculate those limits. So going back to the overdispersion issue that Gary described earlier.
Thanks, Emily.
So there's an admin at RSS. I'd like to know if do you have any examples of success stories where a problem's been identified using SHMI and improvements have then been made?
I'm not. I can't discuss specific examples, to be fair, because it's some of the issues that we investigate are sort of on a trust by trust level. I don't know whether any of my colleagues want to come in and give a generic example that would illustrate that, but there have been issues in the past where we can definitely talk about the sort of the data that's being captured and the impact that that has had on the SHMI value, and how we have been able to improve significantly the data quality in terms of identifying a specific issue and then that being investigated further. And I don't know, let's not speculate what may have been happening, but yes, there are a number of cases where the data has been used to identify an issue that then has a positive effect within that trust.